Hello, my name is Dr. John Foran. I'm a consultant cardiologist and I work at St Helier Hospital in Surrey and the Royal Brompton Hospital in London. Patients with atrial fibrillation are at increased risk of stroke. This increased risk comes from the fact that blood, which is not flowing normally through the heart, can stagnate and form clot. There's one particular location in the heart where clot tends to form, and that's the left atrial appendage, which is a thumb-like structure, hollow inside, attached to the left upper chamber, the left atrium. And we think that the majority of clot that causes stroke in patients with atrial fibrillation comes from this location. It's out of that understanding that people have considered left atrial appendage occlusion or closure as a method to reduce risk. In other words, if we can actually take away the area where the clot forms, or the area where the clot may embolize from to cause stroke, then we might be able to reduce the risk of stroke without needing to resort to medical therapy, such as warfarin or other anticoagulant drugs. Warfarin is a drug that's been around for more than 50 years. It's certainly very popular in the Western world. It is certainly very effective. There are numerous studies which show consistently a 2/3 reduction in risk from warfarin of stroke. So we know warfarin works. The downside of warfarin is that patients have to be tested frequently to make sure their blood levels are correct. They sometimes have to watch what they eat or drink, otherwise their levels will be less than optimally controlled. And of course, if the blood is not thin enough, the patient remains at risk of stroke. And if the blood is too thin, the patient is at risk of bleeding. And these are the main drawbacks of warfarin. Of course, a number of other drugs are now becoming available to challenge the role of warfarin. Some of the benefits of these drugs are that they do not require blood testing. You do not have to worry about taking other medications or watch what you eat or drink. But still, it's a drug that has an effect on thinning of the blood, and as a consequence of that, one side effect, one downside, if you like, could be the risk of bleeding. INR is a term used for the International Normalized Ratio, so it's a measure of how effective warfarin is, and typically we'll aim for a target measurement of 2.5. The range may be between 2.0 and 3.0, and by using the term INR, we're able to test blood in any location in the UK or internationally and get a similar meaningful result. The Watchman device is placed at the mouth of the appendage, and there is a fabric covering which will eventually seal off the appendage completely. To begin with, the fabric is porous and it allows blood to pass back and forth through the device. But that's important to the process of what we call endothelialization to take place. In other words, cells will settle down on that membrane and form a new skin over the device. And that skin ultimately is continuous with the mouth of the appendage, sealing it off. And when the appendage is sealed, no blood can get in, no clot can get out. There's still a relatively low level of awareness that the technique exists, and so it tends to be people who we come across as specialists who come unstuck using anticoagulation therapy who are offered the left atrial appendage closure approach. This being said, the National Institute of Clinical Excellence, when they revised their guidelines on left atrial appendage closure or occlusion, said in 2010 that the procedure can be offered routinely as an alternative to warfarin in patients who are adequately counselled about the risks of the procedure and the other alternatives available when it comes to reducing their risk from AF and its thromboembolic consequences. Left atrial appendage occlusion involves a procedure which is performed under local and general anaesthesia. So in other words, we'll freeze the skin at the top of the leg to allow comfortable introduction of the tube that deploys the device, but we'll also put the patient to sleep. so that they're comfortable from the point of view of the imaging which takes place before the procedure and during the procedure. Patients will typically be left on warfarin and be given aspirin prior to the procedure, and during the procedure we'll take pictures to make sure the device is properly positioned within the heart before it's released. The overall hospital stay is generally quite short. Most patients that we've treated so far have been admitted the evening before their procedure and then go home the morning after their procedure. So far in our group of patients we've managed to discontinue warfarin in all patients, though some patients have had to wait up to a year for this to take place.